Welcome to Vision 2020 USA's Spotlight Series. Today's topic, Results from the NYC-SIGHT Study, featuring Dr. Lisa Hark, Professor of Ophthalmic Sciences and Ophthalmology of the Columbia University College of Physicians and Surgeons. The Spotlight Series is hosted by Dr. Rajiv Ramchandran, an Associate Professor at the Flom Eye Institute at the University of Rochester, and Dr. Dean Van Asdale, an Associate Professor at the Ohio State University College of Optometry, leading members of the Vision 2020 USA Executive Committee.
All right, well, it's just after 3 o'clock, and I welcome you to our Vision 2020 USA Spotlight. So thanks for everyone who's joined. This is a great crowd. We have today our distinguished speaker, Dr. Lisa Hark, who is a professor of ophthalmic sciences and ophthalmology at the Columbia University College of Physicians and Surgeons. She is director of the clinical trials unit in the Department of Ophthalmology at Columbia. She has been principal investigator of the Manhattan Vision Screening and Follow-up Study, which is NSIGHT, since 2019, and she was formerly director of the Department of Research and director of the Glaucoma Research Center at Wills Eye Hospital in Philadelphia from 2009 to 2017. Her experience is extensive in overseeing research grant development, clinical trials, and assisting faculty, fellows, students, and medical and residents in conducting and disseminating their research findings. And today she's going to talk about her results from the New York City SIGHT study. But before she starts and before we have this, we're very thankful you all are joining our Vision 2020 USA Spotlights. And Dr. Dean Van Asdale and I have sort of put this together to get the conversation going about various programs across the United States that are engaged in improving access to eye care and improving health outcomes. And so now that we've done it a few times, and many of you are experienced at hearing these sessions, I task you to think about what are the key outcomes that you would be interested as a stakeholder in this process, in this type of program that we're going to be talking about today. What are the things that you may be looking at, and what are the things that you may think that funders of such programs or supporters of such programs would be interested in looking at, so that we can get the discussion going about the importance of having some standardizations in what we're measuring and what these outcomes that we're looking for are. And with that, I also want to alert everybody, as I know people will have to sign off maybe early a little bit, that next week we actually have a counterpart of our discussion today. It's Dr. Paula Ann Newman-Casey speaking about the NSIGHT program in Michigan. And so it'll be a great juxtapositioning, or not juxtaposition, but a complementary discussion next week on Monday. So it's a double header for November. And with that, I turn it over to Dr. Hark to start a presentation.
Thanks, Rajiv. Thank you so much. I'm going to share my slides, and then we'll get started. If everyone can hear me and see the slides, just let me know. I'm going to take off all these photographs.
Perfect.
Can everybody see?
Yeah,
yes?
Looks good.
Okay. So this grant was funded by the CDC. These are the two numbers, and the other number is we were the coordinating center as well. So my goal today is I'm going to briefly introduce CDC organization, show you where this grant is coming from, so you can think about that for your own foundations and organizations, define social determinants of health, which I know most of you know, but I'll give you the perspective, talk to you about our population and the study design, and then we'll present the statistics and the findings. So this grant is coming out of I'm sorry for this bar here, the Vision Health, the Centers for CDC, National Center for Chronic Disease Prevention and Health Promotion. And that's over here. CDC has many organizations. So within the National Center for Health Promotion and Disease Prevention, there are 8 divisions, and we are within the Diabetes Translation. That's where the Vision Health Initiative is coming out of. It's in the Division of Diabetes Translation, like I just said. So in 2018, an RFA came out improving detection and management of glaucoma and other eye diseases. in high-risk populations. And the study was aimed to support strategies, innovative strategies, in vulnerable populations and have the least likely to have access to eye care and detect and manage glaucoma. It was mainly focused on glaucoma, but because when you're screening for glaucoma, obviously you'll find other things. So we determined that the coordinating center and the entire study would be called SIGHT, and that was Paula Ann Newman Casey's idea. Screening and interventions for glaucoma and eye health through telemedicine was where SIGHT came from. I was funded as the PI of the coordinating center, and then there were 3 sites that were funded, which you'll hear Paula Ann next week, and University of Alabama at Birmingham, Lindsay Rhodes and Chris Gerken. Is this bar cutting off the top for your view or not? Oh, okay.
No.
So Dr. Chaffee is our chairman, as you know, and hopefully most of you know many of these people, but we have glaucoma, we have retina, we have cataract, we have economic analysis. We partnered with Westat to help us, and we have a lot of glaucoma people. And we also have our study optometrist, which is Dr. Diamond. So a lot of the initiatives before everything changed was to really rev up and focus on social determinants of health. And I know most of you have heard of this. The 5 elements of the social determinants of health are here, and we are focusing on the neighborhood and built environment and improve access to eye care. So we are bringing eye care to where people live, not in their apartment, downstairs in the community center. But the reason is because I'm just going to try to hide this panel. And then I will be in a better position here. Okay, so the consensus is poor follow-up after eye screenings was what I had been told for many years when I was at Wills. We did lots of screenings, Washington, D.C., and lots of screenings, but people weren't following up. So I wanted to bring eye care to the community where people lived. I was moving to New York at that time in 2018, and it required significant partners in order to bring eye care to the community. So our study design, our major partner was what we're calling New York City Housing Authority. And this is an example on the left where you'd have one development would have over 2,000 residents. So when we talk about 10 housing developments in Northern Manhattan, that was to access 6,000 people. That was the cohort. And we were looking for people over 40. Some of the buildings had families, some of them were senior buildings. This is a senior building in the middle here, seniors only in New York. Anybody over 60 is a senior. We decided to make it a 2-to-1 randomization, which came out of our advisory board and our data safety monitoring board so that more people would benefit. And we did a cluster randomization, which meant that certain buildings were going to get the intervention and certain buildings were not, because it would be impossible to do an individual randomization because their neighbor would, find out. So the intervention, 7 of the NYCHA developments gave us access to 4,500 people. And the intervention was very simple. If they were referred, I'm seeing 2 questions. Okay, sorry. So they got free eyeglasses. Warby Partner was our partner. And if they were referred to ophthalmology, that they would be assisted with patient navigators. And it was a very simple intervention. I recommend when you're doing your own interventions, keep them very simple. If you're referred to ophthalmology, what we did was we scheduled everyone in the usual care group for their initial appointment, but then we did not remind them, we did not give them any assistance. We also did not provide free eyeglasses. We gave them the prescription and the list of optical shops. So this is another development called Wrangle, and this has, you can see many, many buildings over here within that. So these were the list of our buildings. Our statistician did a random selection based on the number of people in these buildings. And we went to the development community room or the senior center or the health clinic, whatever was, you can imagine that when there's 2,000 people living there, there's community space. So 2 days a week for 4 to 6 weeks at each development. And this is just a picture of Upper Manhattan, so you can kind of get a sense of Columbia Medical Center up here is at the very top. And then Harlem Hospital is right here. And that was very important that we had both ophthalmology. We had places to refer to them, because someone who's living down here, they don't really want to go all the way up top to up there. They want to just walk over to the ophthalmology over in Harlem Hospital. So these were the kind of locations. To be eligible, you wanted to be living independently in a NYCHA development or a senior center member. And this was important because if we were using the senior center space at the NYCHA property, we wanted to also be able to include the neighbors who come to that place. We couldn't say, no, you couldn't join. And of course, we were right in the middle of COVID. So the grant was submitted in 2019. 2019, we were funded. COVID hit in March. We were shut down for a year, which allowed us to change to some very interesting things, meaning phone consenting. And then we got back up again on 2022. Everything was translated into Spanish because many of the residents speak Spanish, and especially the older patients, and some buildings were primarily older senior buildings. It's important to keep track of how people find you. So we hung flyers, we hung signs outside. You can see in Spanish and English. This is a sign in the lobby of one of our senior buildings, and this is one of the senior centers. And we had lots of different ways people came. So because it was COVID, we were able to do pre-screening over the phone, which saved us hours of time. And I highly recommend all of you try to assess eligibility, consent and enroll, do all of your questionnaires, do your quality of life questionnaires, and even we asked falls questions. So the two questions that we asked over the phone to determine if we were going to be able to do a falls assessment. Now, why falls? Well, because falls are a risk. Vision related to falls is linked, and cataracts, and even sometimes getting progressive glasses, people are more likely to fall. So, and it's a major public health problem. So we asked people, do you worry about falling or feel unsteady when standing or walking? These are the steady, which is the CDC falls assessment. And have you fallen in the past year? And if you did, were you injured or taken to the emergency department? That was the determination. If they answered yes to any of those questions, then when they came, we did the 30-second chair stand, the time, get up and go, and the 4-stage balance test. So our screening consisted of 3 things after we did all those questions over the phone, and they were very simple. We checked vision, and we used community health workers to check their vision. We trained them, and if they were 20/40 or worse, they failed. If they had an IOP, we used the eye care tonometer, which didn't require anesthesia, and if they were 23 or 29, between 23 and 29 millimeters of mercury, they failed. If they were above 30, then they were referred immediately, and I'll show you that. And then Volk donated a camera. I recommend you, whatever camera you're going to use, make it simple. We had no internet because I did not want to worry about any of that. So when we got back, we were able to upload the images. So the options were, they failed if their image was abnormal or unreadable. If it was normal, obviously they passed. So we brought an optometrist back 3 weeks later who saw all the people who failed, and we conducted a autorefraction, which we used this quick see device. We did a non-dilated eye exam with a portable slit lamp. You can see Dr. Diamond using that now. And then we used the loose lenses to determine the eye prescription. Now, others have done this very differently. Some people have just used this autorefractor and made glasses with that. Some people have just waited for them to refer, but we wanted to bring everything to the senior center or wherever. Anyone who wants a copy of the slides, I'm happy to send, Anne will send you the slides because there's a lot of references in here. So I highly encourage you to publish your design and methods and break down your big studies to publish lots of things. And that's what I'm going to show you now. So we published our design and methods, and then we were able to document our demographics. So we had intervention. Our mean age was around 68. So I'm going to talk a lot about results now. And you can see the age ranged 60 to 79 was, you know, the sweet spot, but we did range from 40 to 98 in both groups. And we had about 65% women and 35% men. And a lot of that has to do with the women are more likely to go to the senior center. We did not do any major, you know, recruit men versus women. We had almost 48% Hispanic in the intervention group, 32 in usual care. And again, that was just random by building. There were more African Americans in the usual care group. We don't think this affected our results. However, you know, it was a very diverse population and mostly underserved minority patients. We had CIS, a lot of people spoke Spanish. You can see 43% spoke Spanish. We had a few other languages, but I had a primarily Spanish team with us. And the most interesting thing about New York is that 96% of the people had medical insurance. So they had Medicare or Medicaid or both. Some had private and many had supplemental. So insurance in the past has always been an issue. We had to pay a copay or all of that, but that was not true of this population. So since we had all this social determinants of health data, we wanted to share it with you, which is the majority of people were single. There was a you know, variety of people across all groups. Most were less than high school or high school graduates, some college, and many were retired, some were working full-time, part-time, and then some were unemployed or disabled. And the other interesting thing was that most people did not need transportation. And, you know, your settings are very different, but in New York, you know, people are used to running around on the bus. And I had like 90-year-old women telling me they'll be fine, I'll take the bus. So in terms of medical conditions, these are all self-reported, and that's why I put it in red, but we had most people reported hypertension. This was about 70% had hypertension. And then these other issues we asked, foot problems, because we were on we had the steady test, which is the stop accidents and falls. And so you can see there were a variety. We had 206 people who actually told us they had diabetes. And then we asked about what are their ocular conditions. Many had dry eye, blurry vision. And then 85 people were taking glaucoma medications, and that was our proxy for having glaucoma. And we asked them, why did they not have an eye exam in the past year? And there were 378 out of the 708, which is, you know, about half had not had an eye exam in the past year. And the reason was no reason to go, except I'm going to show you some data in a little bit, which will show you it doesn't match up. No insurance was not a big issue. Many people were just saying it was COVID. They don't want to go to the doctor. But this not thought about it and no reason to go is interesting because people were saying, we asked the NEI-VFQ 9 questionnaire, which was very brief, the vision, function, quality of life. They had two general questions. Would you say your eyesight in either eye, if you wear them, is excellent, good, fair, or poor? And you can see that, you know, most people were in the good, fair, poor group. But then when you ask them how much time do you worry about your eyesight, it came down to the majority were some of the time, most of the time, or all of the time. And what we were able to do was, of those 708, we resurveyed them again. About 500 people were able to be resurveyed in 1 year. And we were able to publish improvements in vision-related quality of life after people who were in this group. And we compared the intervention for the usual care. So you can read about that. We also were able to publish the steady data, which was very interesting. We had 42% worried about falling or felt unsteady when walking. 55% had fallen in the past year at least once. Then it was 2 to 3 times, and then 3 to 5%. 3 to 5 times was also, you know, plenty of people. So after they did the steady test, which I told you what those 3 tests were, they were classified into low, moderate, or high risk. And then we were able to also get that data published. And that was in the BJO. So that's also available for you to see that. What was most interesting was, most of you know, if you're over 80, you're at higher risk of falling. We did a regression analysis to see what were the factors associated. and blurry vision, obviously, but high blood pressure, arthritis, and also foot problems was also associated with falling. So then the screening results that you want to see, the great news was that, and I wouldn't say it's great, but we had almost 80% of the people that we screened actually considered failing the exam. And failing, again, I told you, was 20/40 or worse, IOP 23 to 29, or an unreadable image. And they could have either one of those. So you can see that multiple reasons for failure. Almost 500 people had the vision, so we knew all those people would benefit from the glasses if they were in the intervention group. And then you can see the IOP and the unreadable. Now the unreadable ended up being around 12 to 15%. So we had a pop-up tent, and we put the chair inside the pop-up tent, and we did retraining on the camera, and we only had one person taking the images, and that really helped. So keep that in mind to improve your readability of your images. The visual acuity results spanned all the way from 20/20 to NLP, and you can just see here that our cutoff was 20/40 or worse. And we had lots of people. This is, the frequency here. We had plenty of people that were, legally blind, so we helped them with their low vision forms. In terms of IOP, we were saying the normal was less than 23. So the mean of the 706, right eye, left eye, was about 14.8 in both eyes. And then what we did was anyone that had above 23, we took a second reading. So there were 85 people with the second reading, and you can see how the mean shifted. Okay, so this little red dot, the mean for this 12% of people ended up being, between 22 and 23. So then there were these patients that had an IOP greater than 30, and there were actually 7 of them running around with like pressures of 40. So we brought them to the clinic the same day at either Columbia or Harlem Hospital, and this is just Steph taking this is a real patient, and these are both real patients that actually saw Dr. Valenzuela the same day, and he did diagnose glaucoma and gave him drops, and I helped him get the medicine. So always do a satisfaction survey because it's very helpful. Obviously, convenience in the community was extremely important. The donors like this, the papers like this has all been published in our baseline findings. And you can see that no one was dissatisfied, and our team did that. So this was published, and I saw Davina on here, and she's helping us with our current study with cost. But we also published our baseline results that I just showed you, as well as cost. It was about $199 per patient that it cost to do the screening. And then when you added the Ophthalmic, it came to about $250 a patient. So it was very economical for all of this. Telemedicine image reading results, which is also important. Obviously, you all know about telemedicine. We did glaucoma specialist and a retina specialist. Okay, now I know everybody's reading images with AI, but this was about 3 or 4 years ago. And so we had the choice of abnormal, normal, unreadable, or abnormal with no significance. These were referred to ophthalmology. If they were abnormal, they bypassed. Now the images were read about 2 weeks, within 2 weeks. So that was allowing us to get the image results before the patients came back 3 weeks later to see the optometrist. Why did the unreadables refer to the optometrist and come back? Because we didn't want to over-refer, and many of them pretty much had cataracts. And that was a determination of our Data Safety Monitoring Board. So again, we had 137 people with glaucoma findings and 157 with retina, and some had more than one finding. But overall, for the glaucoma, these were the reasons, and they could have more than one finding. So they had an abnormal disc, or they were asymmetric, or they had rim thinning. And you can see this. And again, this was a criteria that was determined by our glaucoma specialist. And the regression analysis showed that they had a higher odds of being referred for glaucoma and having glaucoma, again, if they had pre-existing glaucoma, which is very obvious, but IOP also, which confirmed our having IOP. And then this very strange thing, which was, we had a small n of this, but needing assistance with transportation actually bubbled up. And I'm not sure if that's because, the ones that need assistance are not following up and are less likely to be controlled. So we're not sure about that. But one of the next grants that we did, which is under review now, if the government ever opens, is to provide transportation. So this was published in Journal of Glaucoma this year, all of our glaucoma findings. And then we wanted to look at our retina findings because we had a retina specialist who had like 50 things on the review that he was doing, Dr. Horowitz. And one of the interesting things, we had 43 people that he deemed suspicious for retinopathy, but we only had 25 people report having diabetes of these patients that ended up being, getting imaged. So that was interesting. And you can see that the paper that we published for retina, we broke down all of the findings here. So they could have had an abnormal image, but still pass the exam. And that's very important because it made us feel like it was very important that we did this picture, this retina image in the community. And then, of course, some of them failed the exam, but had a normal image. So once we sorted all of the options out and what to do, then we realized 22% were referred for retina. And the regression analysis showed that this was new. Self-identified with pre-existing glaucoma were more likely to be referred for retina. So I think now, well, anyway, we know diabetes is now a risk factor for glaucoma. So, and then those with severe vision impairment, 2200 or worse, were also more likely to have a retina finding. And that makes sense. So here is in Telemedicine Journal of eHealth, we published all of our teleretina image findings and importance of photography. So then the final results are the optometrist exam. And I think this is interesting because in the past, the show rate is always challenging. But the good news was in both groups, the intervention group, and remember, this was a group that was getting free glasses. Usual care was only getting a glasses prescription. And anyone that needed referral was getting an appointment. There was really not a significant difference between the show rate. So we had, just because we were bringing the optometrist to the community, we had a very large show rate. So the other interesting thing is 71% were referred. So why did they see him? Well, it actually turns out that the ones who saw him were very likely to show up for the in-office exam. So we're building the rapport, we're building the trust, we're reducing the burden of over-referral. And what we found was that 100 people had not had a dilated eye exam in the past 2 years or never had a dilated eye exam. Many had cataracts, some had glaucoma, this was new as well as existing, and some had retina. These were the cataracts. We had 45 people with advanced cataracts, and we are actually submitted our cataract paper. Very few ended up getting cataract surgery. They just didn't really want to do it or didn't understand it. So you need to be prepared for that. These are just some examples of the patients that got the free glasses, and 216 received complimentary eyeglasses, and they were all different. And Warby Parker was an excellent partner. And again, we did a satisfaction on this. Convenience, 93%, very, very high. And you can see they love the optometrist. We were able to get both of these papers published, which was the optometric exams, and then we published the vision and refractive error results as well. So I highly encourage you to publish all of your findings. The total referred to ophthalmology ended up being 66%. 26% glaucoma or suspect, which is a huge number because only about 3 to 5% are supposed to have glaucoma. If you add suspect, maybe 10%. If you add underserved populations with higher referral rates, it's maybe around 12 to 15%. So we're coming in at 26%. And that's what Michigan and Alabama also came in as. So we have a group paper that's coming out in terms of referral rates. And then we had more people in the intervention group. So our final paper, well, this was a paper that a resident wanted to write, so we wrote this together. And this was a sub-analysis of refer to ophthalmology. And Karen and I research picked this up. And so this was describing, you know, all of kind of combination of everything we spoke about. So they were offered an opportunity to see their own doctor, to go to Harlem Hospital or to go to Columbia. The request to see your own doctor, we were not really able to get a lot of good data on that. So if you do that, make sure you get the medical release form right up front if you want to be following their own doctor, because we didn't want to steal patients from anybody. But the big primary outcome of this study was to look at the effect of the patient navigators and how they improved in-office exam attendance or adherence after they went through our study. And so this was just published in AJO, and AJO, remember, published our baseline, so it was a very good fit. And what I want to show you is that you've already seen the refer to ophthalmology. You know that we have the refractive error with the two groups I showed you. You know why they've been referred, and they were 468 scheduled. We scheduled everyone so that we had an index visit. And then if Harlem was going to call people and remind them, we had nothing to do with that. If Columbia was going to do that, we had nothing to do with that. And then we would call them and remind them to go, and then subsequent appointments as well. So what we showed was that the intervention group, of those who attended, you can see the differences here. What I like to look at is those who did not attend were much more likely to be in the usual care group. So almost 62% over here. And the ones who attended, who attended were much more likely to be in the intervention group. And in fact, this is statistically significant that if you were in the intervention group and you did get your patient navigator support, you were much more statistically likely to attend. We also captured reasons for not attending. So again, this was the no medical release form that we didn't get, no show, unreachable, and 9 withdrew. And that's all, because I know we want to have plenty of time for questions. I just want to let you know we had a wonderful advisory board, and we had many partners in New York, and it was, you know, a huge group. And this was our data safety monitoring group and all of our team at Columbia. So here's my email, and I'm gonna stop sharing, I think, right? So, okay.
Wonderful. Thank you, Dr. Hark, for that beautiful presentation and a lot of great data done. And despite COVID, you were able to get to so many people. So that's a wonderful thing. One quick question from Dr. Allison out here in Rochester is, did you charge insurance for the visit, or this is all
No.
free, right? This is all granted.
When they came to the mothership, I call it, the in-office, yes, of course. They all had insurance. We did not register patients because that's always hard. Many of the patients were already in the system. So for example, I was born at Presbyterian, I'd say, or, you know, so, yeah, but we did have a specific scheduler at the place that was very helpful. Oh, I know what happened. We were given slots. And I highly recommend you do that before you go out and into, so it says, what activities do the patient navigators do? So first of all, we got slots. So Stefania is on the call, but I mean, I'll elaborate. You know, Monday, Wednesday, 1 o'clock at Harlem, and then Tuesday, Thursday, Friday at Columbia, you know, in the resident clinic that would take their insurance. A lot of it depended on their insurance, but we actually had the slots. We gave the patient the appointment at checkout. Unless they had an abnormal image, then we called them. And then the activities of the patient navigator would be to help them understand why it's important to go. The main job was calling, reminding, rescheduling. A lot of times it was rescheduling. Yes, we did conduct a post-treatment assessment of patient quality of life. No, well, the the paper that was published with Grafey's on the 12-month follow-up may have included some people that were treated. We did that over the phone and in person in the community as much as we could. We were able to get phone follow-up to improve our numbers. Because, you know, we originally built in a 12-month follow-up. So we went there, but people were not, you know, they weren't staying for that questionnaire. Dr. Brooks, did I answer your question?
You did, yeah. Thanks, Lisa.
Okay.
Hey, I have another question. So you had a pretty high prevalence of pathology in this population. Obviously, there's a lot of need for access to care there. You know, how do you envision, I guess two questions. How do you envision this work in the same site evolving over time? Say, if you're consistently there for the next few years, how might that screening program look once these initial cadre of folks are brought into care? And then how do you think about, you know, the best way to adapt this screening strategy to different populations where, you know, you might, like we work more in rural areas where maybe there's a lower prevalence of pathology. How do you think about those application of the strategy you used in different settings?
Well, we are applying and have applied for additional funding to return to NYCHA and blow it up. And NYCHA has been working very closely with us. This almost turned into a pilot project with, you know, but the fact that we got 700 during the 2 years of the worst 2 years ever in New York, everybody was very happy with that. I think that overall there has to be funding. I know everyone asked me, how can I do this without funding? But there has to be funding. And I think depending on the level of funding, I think 5 years is great time to commit. And, but you have to have a place to send them that can take their insurance. You know, I don't think sustaining community outreach, I just, the equipment is just so expensive and so heavy in ophthalmology that we do need to get them back to the clinic and back to the office at some point. Can you go out and screen with an IOP and a vision and not even use a camera? Sure. But you could see how beneficial the camera was. Now they're coming up with all kind of technology to put on a phone. I'm very aware of, you know, we have a lot of technology that we're looking at now. So, I don't know if I answered your question, but
that was very helpful.
The pathology is extraordinary, and it's very, very important that we, you know, improve this access.
I guess I have one follow-up question, if you don't mind, Lisa. You know, so how do you think about the strengths and weaknesses of applying screening programs to, you know, one, maybe a setting like where you work, where there's a lot of folks with sight-threatening disease that you detected and brought into care, versus, you know, applying the screening model versus a clinical model to settings where there's not as much pathology. You know, you
Right,
need to
I
find some
understand.
sweet spot in the middle there. Yeah.
Right, so I mean, I would say the family history of glaucoma is very important. Again, I'm sorry to focus on glaucoma, but that's what this grant, well, I mean, you know, past and present, but family history, I mean, you all know the risk factors. I mean, but I think over 40 is where you want to start. And because we all know, you know, between 40 and 60 is really where you can make a big difference. 65, 40, you know, so don't steer away from the younger people. Paula is doing, Paula, I see you're on, she's starting at 18. And of course, there are more referrals for that, for other things, refractive error and things like that. When you're looking for the eye diseases, I mean, the lady who had the pressure over 40 was 41. So, but she had a very strong family history from Nigeria, you know, of both parents and grandparents blind from glaucoma. So, yeah, you know, so I think the family history is a big issue. Diabetes, obviously, anyone with diabetes, you know, so to target, what you're talking about is targeting screening so that you're more effective.
Yeah, exactly.
Those are the two things. And I think obviously also certain groups of race and ethnicity are higher rates. We all know this. Hispanic and African Americans are higher risk. So you can, target. What components were included in the screening cost estimate, for example? The cost estimate for the screening included the start and end time. I'm not sure where Scott is on this, but the start and end time, we did micro costing, and we had Laura Peasy was our consultant, and she helped us set this up. If you look at the AJO paper, it lists all those, but we did start and end time of visual acuity. We did all the clinical costs. We did not do the research costs, consenting and surveys and all that. That doesn't count. So it was the start and end of the visual acuity, start and end of the IOP, start and end of the picture, the time the doctor read the thing, which took like 5 minutes, and then the time of the optometrist. We may have included travel time, and we got the equipment loan, so we estimated the cost of the equipment. And then I think you do study startup costs as well.
So I had a question to follow up. This looks like a great program to connect the community with the established brick and mortar eye care entities that you have in New York City. So was there data that Columbia and leadership would like to see in ophthalmology to see how this was beneficial for drawing in patients into the system in a methodical fashion so that you could screen and triage people appropriately to get the highest level of care they needed?
Was there data, or was everyone happy? So the main place where a lot of the patients ended up being seen was Harlem Hospital. And yes, they are thrilled that we are referring patients to the ophthalmology department. Absolutely. We are affiliated with them. We run that ophthalmology department. We did not refer to Sinai or any other place just because we didn't have to. We did not provide transportation. But there's never enough appointments.
Right.
People cancel and reschedule, and then also places cancel patients. So it's a challenge. It's a challenge. I think going there with those appointment slots made a very big difference.
So what kind of data did you have to show, like leadership? Is this filling up appointment slots basically? That's what they kind of looked at, or what was
No,
their
we didn't have, this is all about getting funding. So we
funding?
didn't have to, I didn't have to do that with this. On the other hand, I have given this presentation a number of times to leadership at a lot of the different institutions, as well as the Department for the Aging, our major partner, NYCHA, reducing, making it more, less technical. It's very challenging to get into these type of community settings. And it took a lot of trust and handholding and building and partnerships and transparency to get NYCHA to approve this, especially during COVID. And then now again to go back and expand it. So they recognize that eye disease is a very big problem for their residents. They call residents. Many of the residents are working. So our new approach is to do a Friday, Saturday in a larger event and draw all the people in from whatever buildings we're going to be in our cohort, rather than just go to one building for 3 weeks and then go to another building, another development for 3 weeks, So we're planning like 6 events in 1 year and have 15 developments involved, and everyone can come. And then, so that's under review right now with NEI or NIH or whoever. So Yeah, so we use this as a building block to really expand.
Can I ask a follow-up question,
Mhm.
Lisa? I was wondering, you had really great follow-up rates, as you mentioned. Do you attribute that? It sounded like convenience, the location was key there, and the patient navigators. Do you have any other insights there? Because I've seen a lot of other studies where they've done a lot of interventions, free transportation, free exams,
Right.
communication, phone calls, and it's always been like 40 to 60% follow-up rate for definitive exams, and you're, 80 or 85 is what I
Yeah,
saw.
well,
So,
the 80, just to be clear, was for when we brought the optometrist to the same screening location,
okay.
which I recommend. Now, just because, that 20% that didn't show up, I'm obsessed with making sure everybody gets the care. On the new project proposal, we're bringing the optometrist the same day.
Good.
Okay, because you don't want to miss people. Okay, so we're going to have a bigger space. Picture those 6 events a year, bringing 2 optometrists actually. Screening 500 people in one room at one time over a couple of days. And then, you need to see the optometrist. They're right there. You can't say no. So, so go right to the optometrist. So I think that was a big change. What was the other thing you were asking?
Yeah, well, that was the main question. I actually have another question. Sorry to pepper you with so many questions, but so like you say, you don't want to miss anybody, and even in the scenario, the design you used, 20% of folks didn't come back for
Oh, you
that.
were saying what, right. So I think that having the Spanish speaking racial concordant staff, it cannot be underestimated. I think that we developed a major rapport with people over the phone. I did a lot of the phone calls, and then people come in and they meet you and they want to talk to you. And then we, gave them brochures, and then we called them again and in Spanish, and then we text them in Spanish if they want texting. So I'm seeing a few questions. Did you charge the insurance company for the visit? That was a while ago. We already said no. Okay. So yes, we charge the insurance company if the patient had insurance at the clinic, but Harlem takes patients that don't have insurance as well. So that was always our safety net. Yeah, so I mean, I think that another thing that helps is if they have a peer support system, especially for people that have had cataract surgery, for example. Oh, I had it and I can see great, and I got the other one done, and now I have great vision, and they were terrific. It makes their family member more comfortable going, or their friend. Many people did not have anybody to go with them or take them or whatever. And I know that our cataract surgery people provide transportation and just send them home and, things like that. So I don't know exactly, how to get them all in, but I think having an understanding that it's gonna, there's a lot of variables there. You all know these issues.
So how did you choose your sites? Was it just because you had those relationships, or was
Oh,
there some type of strategy?
yeah, that's a really good question. So NYCHA is the largest landlord in New York. They have what they call they have like 489 developments in the 5 boroughs. So I was not going to drive an hour to go to Brooklyn or Staten Island or the Bronx, or, there's other medical centers and people, so we tried to say to them, okay, here's Upper Manhattan from Harlem Hospital up to the medical center where I showed you that map. Where are the NYCHA developments here? And which ones, would make the most sense. And I didn't come in there with any prescriptive. I'm of course not from New York, I'm from Philadelphia. So I didn't even know what building was where, and so we just had a lot of meetings and we toured all the buildings, spaces, and, and we decided based on, what would work best. Did Columbia see patients as well? What percentage of optometrists, ophthalmologists, were of the same racial and ethnic group as the patients? What percentages? I would say it was about 50% of my staff were either Hispanic or African American. In terms of the doctors, the results of that. I mean, we're all trying to get more, race concordant, but I know that there's a very bilingual staff at both institutions. So, including photographers and imagers and techs and front desk and, everybody speaks Spanish. So that's how we selected the sites. For the new study to expand, we went a little higher up north to Dykeman, which is just another maybe half a mile north of Columbia. And then we added a couple more buildings east and west for the new. And we're proposing 14 developments for the new study that I'm going to be trying to do. Here's another question from Kara. What do you feel are strategic investments that the federal government can make to scale? Scale the methods and impacts you have experienced with your research. Strategic investments. That's a big question to think about in 5 minutes, but thank you for that question, Kara. I would say that if there are people that want to go out into the community, those are the people, the strategic investments, is it an organization? I mean, there's a lot of things going on. I'm not sure how to answer that. Does anybody have any input? Paula, you got any thoughts on that? I'm calling a friend.
I mean, I think there's definitely wonderful ways to scale these programs. I think thinking about providing eye disease screening in locations where there are likely people who are underutilizing eye care and at high risk of eye disease thinking about senior housing buildings is a wonderful way of scaling eye disease screening in the US, especially as the population ages and it's harder and harder for seniors to potentially get around. I mean, New York is lucky. You guys have public transportation. In other places, there is no public transportation. And so bringing screening to where people are in senior housing buildings, low-income housing buildings, I think is a really great concept that could potentially be funded by Medicaid and Medicare. They have a glaucoma screening, reimbursement mechanism. If you had charged through that code for all of your glaucoma screening, people did have risk factors, you may have been able to recoup the costs of the program. So I think there are scalable ways to think about that. Now, I don't know that people will be making boku bucks on screening folks in senior low-income housing buildings, but they may be able to break even, and some of the downstream revenue to, let's say if it's a community academic partnership, may be able to partially sustain the program too if there's an increase in referrals for true positive disease.
Yeah, and the senior age varies. I'm seeing is this a new question?
Yeah, it's interesting to see that there
how do you
was not a
navigate any
significant.
local optometrists? Were there any? No, we didn't have any. You have to understand that 70%, and this is a real number, had not been to the eye doctor in 2 years or more. So as far as like having an eye doctor, we didn't feel like we were taking anybody away from anyone, and we certainly gave them the choice. And I think when you're starting this, you want to give them the choice. especially those who are already diagnosed with glaucoma, who think that they're done their bottle and of drops and that's the end of it. So, you know, so we help remind people to refill that prescription. But you want to build in many different scenarios, because there were many things we didn't really expect and they happened. You know, like, I have a doctor, but I want to come to see you, or I had glaucoma, but I thought I didn't need to take my drops all the day, you know, or I think I'll get laser, but I'm too scared. I mean, there's a lot. I had a woman who was 41 pressure, and she came back to us in 12 months, and she was still 41 in both eyes. And she's like, I'm deathly afraid to get this laser. So even though it doesn't touch the eye and all the other things, there's a lot of misconceptions out there. Same thing with the cataract surgery. So there is that level of education that does need to do it. But combined with a peer who had it, who is doing great, I think that's very, you know, it helps people. But there's many, many, many levels that we all have to do. But I agree with Paul Ann about the senior housing. There's many infrastructures. They're working in federally qualified health centers, primary care settings. So there's a lot of work to be done, and I appreciate all of you joining, and we'll send you the slides tomorrow. If you request, just go through Anne. And Rajiv, thank you so much for...
Sure. So this is wonderful. Thank you, Dr. Hark, for doing this. One quick last question is, there seemed to be no difference between the rates of follow-up between those who are normal and who had the intervention. Is there symptomatic kind of predisposition to why people followed up if they had some type of symptoms of vision, or?
I'm not sure, what do you mean by normal? You meant usual care, or normal patients were not referred?
Okay.
Normal patients were told, go back to your eye doctor in 1 year, or come see us in 1 year. And right now we're in a position where we have a few glaucoma fellows now who are very interested in, thanks Davina, in long-term follow-up. So we're going to be reaching out to these 189 people who had glaucoma, and we will be seeing, you know, the long-term follow-up and help the people in the usual care group also. So I do encourage you, if you do get funded and you have a big study like this and you need to have a control group, you can always do a crossover when the study's finished and give the control group the intervention as well. Not glasses and everything like that, but we are starting to call the usual care group patients now as our follow-up, you know, 3 or 4 years later. Because
That's
they're
great.
probably not in care.
Right.
So some will be, but some might not be. So we're going to just, you know, we're going to track that.
Great. I think that follow-up is really key. You know, you're not in there just to do your research, but you're there to help the community, and that's the key thing for these relationships. Well, thank you all for joining. We're going to have this video on our YouTube channel, and as Anne had sent out in the chat, we're going to have the presentation made available. Thanks to Dr. Hark for generosity of sharing the information and all her publications. And next week, we'll have continued this conversation with Dr. Paula Newman Casey talking about her program in Michigan and talking about federal qualified health centers and the same type of outreach and intervention. So thank you all for joining, and hope to see you next week.
Everybody.